Bore da pawb. Good morning, everybody. I'm Judith Paget, Chief Executive of Aneurin Bevan University Health Board. It's my pleasure to be here today. Thank you all for joining us. The focus of the event, as you know, is on urgent primary care. But before I move into the programme, I just want to say a personal thank you to everybody who works in primary care and alongside the primary care community, to say thank you really for everything that's done the last 18 months during what has been a challenging time for us all. I know everybody has worked tirelessly to adjust and adapt the way we work in order to ensure that patients get access to the they need. So thank you. The event today will explore all aspects of urgent primary care, which also does feature in the winter plan in health and social care that's been published today. More of that coming up during the programme. But now, without any further delay, I'm delighted to introduce the Minister, or our Minister, I should say, Eluned Morgan, Minister for Health and Social Care. Minister, you're very welcome.
Oh, well, diolch yn fawr iawn. Thank you very much. And can I start by saying how wonderful it is to be here with Judith Paget, the new Chief Executive of the NHS. And I can't say how much I'm looking forward to working with Judith in her new role. She's done a great job in Aneurin Bevan, and obviously we'll be looking forward to a very challenging time ahead. It's been a tough few months, and I think it's going to get tougher, I'm afraid, and we're all very aware of the very difficult times that are ahead of us. And I hope this morning we'll be able to focus on some of those things that we are interested in addressing in the next few months and years indeed. Felly diolch yn fawr iawn I chi, diolch am y gwahoddiad I ddod I siarad.
Thank you for the invitation to come and
I'm
talk
delighted
here today.
to celebrate an area where Wales is genuinely leading the way on the day we launch our Health and Social Care Winter Plan. Now, choosing to launch the plan at this event with such a wide range of stakeholders present, I hope reflects the importance that I place on the work we'll hear about today in contributing to better, safer care closer to home. Now, this event celebrates the work that you've been delivering over the past couple of years, but also, I hope, provides an opportunity to further engage with health boards and stakeholders to hear what you are doing this winter in and around urgent primary care. Now, the plan will enable health and care organisations to better understand how their work and planning will contribute to those preparations for winter 2021-22. Now, the winter plan provides a framework for regional partnership boards to help finalise winter plans for health and social care organisations. And I expect this integrated thinking to carry on beyond the winter as pressure on services, as you're aware, is now a year-round phenomenon. I'm very well aware of the fragility of our care system. That is something that is very much emphasised within our winter plan. Now, in this context, I see your work in the management of patients with urgent primary care needs as being critical in supporting the wider system, both this winter and into the future. And as we share the best practice and lessons learned from the establishment of new urgent primary care services across Wales, I'm delighted to hear that the work of the Strategic Programme for Primary Care is leading the way in the whole of the United Kingdom on urgent primary care. And I'm pleased to report that our academic partners have advised us that it's not just in the UK, but internationally that we are leading the way on this. And I think that's something we should all be proud of. Now, the need to share and learn from this good practice couldn't be greater. Our health and social care system has been under huge pressure to meet the urgent and emergency care needs of our population for a number of years. Our services are responding to the increased number of complex patients as our society ages. Changes in the types of demands for services should be set in the context of workforce challenges, across health and social care organisations. Now, we're here today to hear about the work that has been done across Wales and recognise the significant opportunity to improve access to urgent and emergency care services. But we also need to realise that there is still a huge amount of work to be done. Now, the challenges of the pandemic have required the rapid development of new approaches in our health services. And as with other services, primary care had to adapt quickly to social distancing measures by scaling up telephone triage and video consultation. We saw GP practices working together to segregate the COVID and non-COVID work. Against this background, there was a recognition of the critical role of urgent primary care within the whole system. Now, the 6 goals for urgent and emergency care provides a framework for improvement across the whole system in an integrated model with health, social care, independent and third sector partners, really trying to make sure that we deliver the right care in the right place at the first time of seeing people. Now, at the first meeting of the 6 goals of Urgent and Emergency Care Steering Board in August, I reinforced the need for a whole system approach with an emphasis on supporting patients as close to home as possible. The Urgent Primary Care Centre Pathfinder work, led by the Strategic Programme for Primary Care, aligns with Goal 2 of the policy goals, and that is signposting people with urgent care needs to the right place first time. Within the context of an integrated whole system response to urgent and emergency care needs, this work links GP service provision and primary care services with the whole system response and seeks to direct the population into the right setting for their care needs. And that's all emphasised within our winter plan. We have a huge campaign going at the moment, trying to inform the public of where they can go for that support. The overarching vision of the project is to co-produce a comprehensive, integrated, 24/7 urgent primary care national model, which enables patients to be directed to the most appropriate healthcare professional at the time they need to access urgent health and social care delivered on a cluster or multi-cluster footprint. The Strategic Programme for Primary Care initially funded health boards to develop the model, and it's since become an integral part of the transformation of urgent and emergency care in Wales. To demonstrate our commitment, we've also made around £7 million available this year in support of local urgent primary care models. I'm aware that this has been an iterative process built from the ground up, approached by health boards based on the outputs of those initial pathfinders. Now, this approach has empowered the workforce to design and deliver the model and has brought together collaborative working across practices, clusters and health boards. The enthusiasm of all people involved in this has been second to none, and it's really great to see that example of getting something delivered at pace. The benefits of this work to increase access in primary care is twofold. Firstly, it builds supply in the service to promote access and meet the urgent care demands. And secondly, the establishment of a service at cluster level gives potential to free GP core time to manage long-term condition patients and also meet the clinical long-term condition backlog. The work on urgent primary care is absolutely here to stay. I've already mentioned that Wales is leading the way in this work. Therefore, it is timely for us to come together and share the learning to date. Working together at a local and national level has been one of the key factors in the progress made so far in urgent primary care. We need to build on our discussions today so we can fully embed this work within the whole system and ensure that it works as effectively and efficiently as possible for the benefit of our population. The strategic programme for primary care is today launching a number of fact sheets and a report that covers the Pathfinder phase of this work, and you can find these published online at the event page. And finally, I'd like to place on record my sincere thanks for those of you that have been taking part in this work. Your hard work is really very much appreciated, particularly in such testing times, and I urge all participants today to fully engage so that we can build upon that excellent work that's been done so far and inform the further development of urgent primary care within our urgent and emergency care system in Wales, both for the winter and beyond. Diolch yn fawr, gobeithio gewch chi ddiwrnod da iawn.
Diolch, Minister. We're really grateful for your taking time to join us today, and also acknowledging the leading work being done by colleagues across primary care on urgent primary care, and also the focus on right care, right place, first time, which I think is something we should all aspire to and work to. And I think much of the discussion today will be about making sure that that national model for 24/7 urgent primary care for Wales becomes a reality. So we're really grateful to you. I know you've got to get on to other things and got a busy day. I heard you myself on BBC Radio Wales this morning launching the plan, so I'm sure there's other things to be done. But thank you ever so much. We're very grateful to you. Thank you very much, Minister.
Diolch yn fawr.
And with thanks to the Minister, I'm now going to move us forward in the programme and introduce Sue Morgan, who's the National Director and Strategic Programme Lead for Primary Care in Wales. Thank you, Sue.
By rurality. Working as a cluster ensure care is better coordinated to promote the well-being of individuals and communities. On this slide, I outline the primary care model for Wales and how it came about and the key components of the model. And the Pacesetter programme that commenced in 2015 was 24 projects on a Once for Wales basis. And the learning from the projects identified 5 themes that were key across all of them. Firstly, multidisciplinary team working at cluster level is the way forward. At a practice level, MDT working is too small, but economies of scales can be gained at a cluster level. The second point is around safe and effective systems to direct people to the right person or the team at the point of contact. And this is to ensure we've got a prudent approach to care and that we are really looking at avoiding duplication and minimising handoffs. The third point is around integrated teams ensuring a holistic approach to care, both physical, mental and social well-being. And really starting to think about the social model of care. Services must work well across in-hours and out-of-hours to ensure seamless care, so being clear about the 24/7 offer. And lastly, success depends on an informed public who have access to a range of community services. Turning to the specifics of the strategic programme for primary care, we have 4 key priority areas for 21-22. First being accelerated cluster development. I talked about clusters being at the heart of the primary care model for Wales. However, we know that the current configuration is not yet optimal in regard to delivering upon the ambition, and that significant change is required to ensure that the vision for clusters can be delivered. The accelerated cluster development work aims to move us to an optimum model for cluster working, positioning clusters as a key player in wider health board and local authority planning and decision making. As well as positioning clusters centrally within the planning landscape, the work also looks to identify the vehicles required to deliver services at a cluster or a pan-cluster level. The second priority is community services, and across Wales, each health board, local authority and regional partnership area has over time developed their historical community service offer in response to the challenges that they faced within their specific health and care system. This has led to significant variation in the community services provided across Wales and a lack of clarity on what the service offer is. This project is a collaboration between the delivery unit, the NCCU and the strategic programme for primary care, and seeks to develop an effective community infrastructure model for intermediate care based upon the principles of right-sizing community services, which delivers best practice for intermediate care and will deliver upon the ambitions of a healthier Wales. Mental well-being, this is our third priority. The pandemic and social distancing measures has impacted the mental well-being of people in Wales, with arguably disproportionate impact on the already most vulnerable. The project aligns to the National Mental Health Programme Board to develop a clear offer at a local level of Tier 01 services and to equip our primary and community care staff to be able to signpost appropriately, thereby making sure every contact counts. The fourth priority is urgent primary care, and of all these priorities, this is the area that the strategic programme has been working on the longest, indeed since the start of the programme in 2018, and is the focus of today's session. So how does this all fit together? I've outlined the priorities of the strategic programme and the themes of the primary care model for Wales. When we consider the 6 goals of urgent and emergency care, there is a really clear read across. To just highlight some examples, the first goal around coordination, planning and support can be delivered via accelerated cluster working. The second goal, signposting, is also a key component of the primary care model for Wales. And the work on community services absolutely fits with goals 3 and 6. So with that context in mind, I'm now going to hand over to Nick Wood, Executive Director of Primary Community and Mental Health and the lead for the 24/7 work and specifically the urgent primary care work. Thank you.
So thank you, Sue. So what I'm going to now take colleagues through is an overview of the work that we did to establish the Urgent Primary Care Centre Pathfinders. So I've got a series of slides which just describe the process really from November of last year through to the end of the financial year in March. As part of the 24/7 work stream, we set out to deliver 2 main products, the first of which was a definition of what we meant by urgent primary care, and linked to that to basically describe and produce an urgent primary care model for Wales. We were very clear that we wanted this to be co-produced, that it was got to be an integrated 24/7 service that provided patients with the most appropriate healthcare professional at the time that they needed it in order to access urgent health and social care. We also set out that we wanted to deliver it either on a multi-cluster footprint or on a small scale within a GP cluster. So the slides will take you through both of those 2 pieces of work, and we'll start with the definition of urgent primary care. What we tried to do is differentiate between what we meant by emergency care and what we mean by urgent primary care. Emergency care has often been well defined as being health and well-being issues that may result in significant or permanent harm if you do not deal with them immediately. Now, many patients that we see on a weekly, daily basis have an urgent primary care need, and this we've described as an issue that may result in significant or permanent harm if we don't deal with it within the next 8 hours. So you can see the differential there between the emergency and the urgent presentation into the system. We then took the urgent primary care definition and widened it so that we could be clear with all of our clinicians and managers what we meant by urgent primary care, so that when we were coming to devise and design a service, we were clear on the need we were trying to meet. So in terms of this expanded definition of urgent primary care, we've stated that health and wellbeing issues that may result in significant or permanent harm, if not dealt with within the next 8 hours, would be met by an urgent primary care service, which included same-day and out of hours primary care appointments, either a phone consultation through NHS 111, pharmacy advice, or a referral to an urgent primary care centre. And if we were unsure what services needed, 111, or in the case of Cardiff, CAV 24/7, could help access and assess and direct people to the most appropriate service. So that we started with the definition, and in order to meet the needs presented in that definition, we started to look at what an urgent primary care service would look like for Wales. So in order to meet the needs and definition of an urgent primary care service in Wales, we started to look at a programme governance which we could establish to meet our objectives around this programme. We set up a very formal and structured governance through the programme, and we wanted to be very clear that most of the ideas came from local health boards and fed through as a bottom-up approach to defining and designing the service. We set up 3 distinct groups of people to support the development of the programme. The first was a Pathfinder implementation board, which was made up of a series of managers, local managers, in each of the health boards to look at the service that they wished to implement across their health board area. Above that, we set up a national urgent primary care panel, which consisted of Welsh Government officials, people from the Strategic Programme for Primary Care, myself as the lead for the 24/7 programme, and members of the clinical teams who represented primary care across all of the health boards. Linked to that, we wanted to have a very clear clinical reference group, which you can see on the left-hand side of this slide, which is made up of a clinician from each of the health boards who look to implement pathways and have that oversight and clinical governance for the programme. So once we'd set up those 3 groups, supported by a programme management office, we started to move to develop the programme and pathfinders that we wanted to implement in each of the health boards. And we were constantly evaluating and reviewing where we were. And as part of that, we set up a national Pathfinder evaluation group, which was really there for shared learning to ensure that all of the programme managers and clinicians who were part of this piece of work could share their experiences, learning, challenges with each other, and that we'd build then a much more coherent product that we could deliver through the Pathfinder programme. And you can see at the bottom of the slide there, the health boards that were involved in the first instance, and how they fed into the whole programme. And on the right-hand side of the slide, we've described our ultimate governance structure in terms of the management and control of the programme, but also that assurance to colleagues in Welsh Government and to the National Strategic Programme for Primary Care to ensure that we were meeting the objectives that we'd set out at the beginning of the programme. So this is just really a timeline of the work that we have undertaken through the Pathfinder programme. We started in September of 2020 to really look at the sort of definition and what we could deliver in a reasonably short timescale through the winter of 2020-2021. And over the next few months, we worked through some allocations with 6 of the health boards, where funding was allocated from Welsh Government to support the development and delivery of the Pathfinders. We set up all of the national panels, the clinical reference group and the service evaluation group, and in effect started to launch urgent primary care centres across Wales. From November right the way through to March, we were launching a centre in each of the health boards over that 3 to 4 month period, resulting in 7 centres being open by the time we got through to February. We commissioned an external evaluation, which was looking at a literature review that concept mapped what we were doing and started to pull out some of the patient reported data that we'd got from the work as it had commenced and proceeded over those few months. And as we got towards the end of the financial year, we'd agreed what we felt was the definition for urgent primary care. We'd established 7 clear urgent primary care centres, and we commenced a full evaluation of all of the work that we'd done so that we could inform the National Urgent and Emergency Care Programme and the transformation part of that programme to secure monies for phase 2 as we moved into 21-22. So it was a reasonably short timescale, and in effect over a period of 6 months, we designed a programme, developed a programme and delivered it at scale right across Wales. We've now moved into the sort of implementation phase, or phase 2, and we've moved away from this being a pathfinder to a much more substantiated piece of work that's been delivered across the 7 health boards that have been involved with us, and we're now moving to expand the service and meet some of the objectives that we've laid out as we move forward. So what did we deliver? So we basically produced a national final report which will be available as part of today, and the highlights from that phase 1 are obviously we had £1.86 million of funds that we shared across 6 bids between November and March of last year. We've provided costed patient measures in 2 of the sites. So you can see from that particular bullet point there that we're actually providing care at less than £35 per patient. And we've seen over 14,000 patients in a period of 4 months. And that number is increasing month on month as we've moved through the programme. We cover now a total population of 1.5 million, so basically half of Wales, 38 of the GP clusters and 234 practices. And the Pathfinder sites have been run either at a health board level or at practice cluster service level. And later on today, you'll see some of the examples of how this has been developed and delivered. The All Wales Urgent Primary Care National Evaluation Framework and Tools have now been developed and include that clear definition of urgent primary care. And we've got collaboration between the Strategic Programme for Primary Care and the 6 goals for emergency care, and how that has been developed and the way that we move to support specifically goals 1, 2 and 3. Many people have said to us, specifically from the evaluation, that we're leading the way, that this is cutting edge work, and we've really started to develop a service that we've never really had before in Wales to meet the needs of the population. As part of the briefing, we've produced a 7-minute brief which provides you with a high-level summary of the work that we've done to date, which we can share with all stakeholders. And there's a series of fact sheets that will be available as part of today that are based upon the learning from phase 1. So as we move into phase 2, we've established a number of key deliverables that we want to move forward. We've obviously done the evaluation of phase 1, and we've now got a clear operational plan for the rollout of this service on a sustainable basis as we move forward, securing funding for the 2 years to enable each health board to provide a consistent service 24/7 and roll it out across all the health board areas. We've linked the work, as I've said already, to the National Urgent Emergency Care Programme, and we're helping shape the response from primary care to the National Improvement Programme for Urgent and Emergency Care. And we've established really an urgent care delivery model for services in primary care so we can meet the various needs of the population. I think it's really important to stress that this has provided additional capacity and resources into primary care at a time when we're seeing demand increase by about 20%. And we're going to further develop the model based upon the outcomes from phase 1, and we're linking all of those outcomes to the work that we're doing with NHS 111 and think NHS 111 first. Really, what we're trying to achieve as success criteria for phase 2 is to increase that capacity to meet the demands that we've seen in the system. We've set out a real clear clinical guideline approach for this so that we can respond appropriately to the right presentations and help with patient flow right the way through the system. We want to improve access in primary care, and this is a way of really defining a clear model for urgent primary care and improving that access availability of appointments. I think it also provides us with an integrated response to the challenges in the system, and we've clearly linked it to the national programme. And it's much better use of primary care resources and the MDT staff so that we can use people in the most appropriate way, whether they're in their practices or whether they're in one of our urgent primary care centres. So as we move forward, this is the map of Wales and the sites that we've got so far. And each of the health boards is looking to substantiate all of these sites across their particular areas and build on the work that we've done in phase 1. What we're now going to hear is a patient story from one of our urgent primary care centres during phase 1 of the work. Thank you.
Right, the story of my thumb, how I come to be here. Basically, I woke up 2 days ago in bed in the morning and I had a pain in my thumb. It felt like I'd slept on it and it just pulled back and it's quite painful on the joint. I shook my hand to sort of to get some circulation into it and got on with the day. Didn't feel any pain or anything other than that. That was it. It's gone as far as I'm concerned. The next day I woke up, it was worse. It started swelling. I couldn't bend my thumb. So then my wife had a look on the internet what it could be. And a couple of things popped up. But it was getting worse, and it felt like I did it with an hammer. It was throbbing and it swelled up. So decided to go to Evervale Hospital. There was a nurse, she had a look at it, wrote some things down and said that I would need a doctor to see it. So she said, took my number and said, a doctor will ring you and ask you some questions and we'll go from there. About 10 minutes later, I had a phone call whilst I was in the car and the doctor asked me several questions. I answered them. And then he said I should come down to see a doctor in Neville Hall to see a doctor physically to have a look at it, which I did.
If you could take a seat in the waiting room, please, and the doctor will be with you shortly.
I was a bit anxious, and then shortly after a few minutes, the nurse called me through.
Hello, Mr. Thomas. My name is Dr. Murugan. How can I help you today?
Which is what I did, and I seen a Dr. Murugan who had a look at it, and she's treated me for 2 different symptoms, and I've got to call back and see her again Thursday. And as it happens, she's a doctor in my local surgery, so which is great. She's a lovely lady. She's dealt with my wife before and fabulous. And gave me a prescription, and I've got to call and see her again Thursday. And I feel so happy that I've seen her. She's a very nice lady. Just came out from my appointment with the doctor. Everything seems to be healing fine. No more throbbing pain. I'd like to thank Dr. Murugan for all of her help. Also, it's a big thumbs up for the NHS Urgent Primary Care Centre. Thanks so much.
Well, I hope you all enjoyed the video that we've just seen, which was a patient story from the Urgent Primary Care Centre at Neville Hall Hospital. The next part of the programme really starts to feature some of the local services that have been delivered, and there's a number of videos and presentations on our local champions and how they've worked to deliver the service right across Wales. So we will go into a number of videos which will run concurrently for you. During this period, please feel free to get yourself a cup of tea or take a comfort break, because we aim to sort of run through the videos and then move into the breakout sessions where the technical team behind the scenes will move you from one room to another as you move into your 2 breakout sessions. There is a link at the top of the page for that, and it will all be taken care of as you move forward. Just to mention as well, in terms of questions, so underneath the video, the screen that you can see me on at the minute, there is a little box. So if you want to put in some questions that we will deal with later on in the live question and answer session, which is towards the end of the day, then please put those in there and we can start to set people up to be able to answer those. So without further ado, I'm going to move us on to look at some real local champions and the great work that they've done over the last 12 months in delivering urgent primary care centres. Thank you.
Our model is based around trying to get the patient to the right person at the right time and at the right location.
Patients access via redirections from minor injuries, hospitals or the emergency department. Ideally, we wouldn't want patients to attend their first time, as it adds an extra step into their journey.
The primary care centre supports both general practice and the emergency department, and ultimately the aim is to ensure that the patient receives the treatment from the right clinician at the most appropriate time, which ultimately would reduce waiting times within general practice and the emergency department.
Work together as a small collaboration of practices who set up the UCC to try and support those practices that have needed it most.
With our journey within Aneurin Bevan, we looked at trying to provide patient care to ensure that patients were able to be seen in the right place first time, knowing that wasn't always going to be achieved to start, but how we could start to educate patients.
We see patients from 7 surgeries, so that's 65,500 patients in total we're covering.
So as it currently stands, we have 5 practices that have joined the service. So that's a population of approximately 34,000 patients that we're actually providing a service to. By the end of December, we are hoping, we are already engaging with another 2 practices currently.
Patients, sometimes I think don't know where to access healthcare, or they have difficulty in accessing care, so they often self-present to an emergency department or a minor injury unit when they're actually more of a primary care problem. So our pathway is if a patient presents to an emergency department or minor injuries, they can then redirect them to one of our urgent care centres. So the nurse at one of those units will see them, do a set of observations, take a history, and then they put them onto our system. What we have then is a hub where usually a GP will ring them back, see how they can help that patient virtually. But if they need a face-to-face assessment, they can book them into one of our 2 urgent care centres.
Simply click on the link, open up the referral form and fill it in. Everything is there for you. All the information that they need is set out in front of you, and then you just press and go basically. So you don't have to worry about it from your perspective.
We are speaking to our care navigators, and we're doing training for the patients, undertaking patients. We try to emphasise that we are promoting the UCC as an extension of their current practice in offering these extra appointments to the surgery.
We also offer a triage service where the practice takes a cursory look and says, yes, that looks like it could very well be hub material. And then someone will triage them and decide whether to prescribe, send them back to their surgery if it's being too complex, or they will send them up to the hub for them to be seen.
We can tap into secondary services a lot quicker, I've found, comparing when I've worked in GP practices, because I'm based in the hospital, all the specialties are around me. So even on certain cases where I feel like patients need a referral to a specialty, although sometimes the GPs, we need to refer back to the GP surgeries for them to make that referral, I also do those referrals myself from the Urgent Primary Care Centre.
What we locally call CAV 24/7, Calton Vale 24/7 service. So we've developed good working relationships with them, and they are able to book patients into our hub from their systems. And that's something we've done over the months, and that's something we're still trying to develop that to enable better working with them.
Been really well perceived. We have a central location, so generally everybody's happy to come along to a different surgery, especially once they understand the setup.
We haven't had much in the way of any negative feedback from the public. I think they're generally thankful that they are getting to see someone if they've attended ED in a far more timely fashion, when unfortunately some of the waiting times of late have been anything up to 17, 22 hours for an ED an appointment. The fact that they're told, actually, no, you've got an appointment 10:30, you will be seen this morning, I think is seen as a very positive thing.
We have got the formal survey that we will want to roll out for patient feedback, but on a regular basis I will contact the patients also just to see if basically asking the question, how have they found their experience in using the urgent care centre. And primarily what I found is that it's been really good for learning for us in the centre, as well with feedback to the clinicians here in the centre of how they've been presented, how they have engaged with the patient, and they've also indicated that in most cases they don't mind travelling as long as they are seeing on the day. Here at the centre, the travelling isn't too much of an issue.
I think patients are very accommodating when the service is being offered to them. There's no, what's the word? I've not had any negativity towards it. I think they feel as long as they are being seen by somebody, it's the best outcome for them. They just want to be seen at the end of the day.
And it's been really positive because they are very supportive of what I do. If they're always available should I need any support and advice as an AMP to a GP. And I've had a lot of feedback from the care navigators, and it's been very insightful to see how they see the service, what problems they've come across, and then I can take that back then to Alison, you know, just to say, oh, what about if we think about this, and maybe we could change this, because it's that communication, isn't it, between the surgeries and it's a continually evolving service, and it's going to do that for a long time.
I think we've still got some work to do on communication with patients. I still think there's lots of work that we need to do around how people can access all of our services, get the communication out to lean hours as well.
Patients, when they've got an urgent healthcare problem, just want to be seen and get treated. I don't think they mind too much which clinician does that, as long as they get their problem dealt with. So I think by allowing them to have increased access to on-the-day appointments, definitely that's been a positive, and the feedback that we've had from patients that when we did the initial evaluation, which was several months back, was very positive. I think 80% said they were happy with the service, and would use it again.
The national networking is that we have been able to pool resources and develop a survey for patients that we can use nationally that will help us capture data on the benefits it's made to patients, and also review when that has prevented the patient from going to another service perhaps. So we'll be able to see what, if they hadn't have been referred to the service, where would they have gone to for help if they were unable to get an appointment in their own GP practice.
The communication with our stakeholders, that being the care navigators, the staff that we've got working in the UCC, which are primarily locum staff, and the staff in the surgery. And we also have a care navigation steering group with representatives so that we can ensure that we are making service improvements and developments and ensuring it is as smooth as it possibly can be.
You know, patients, as Michelle mentioned, have been very grateful. You know, we've had thank you cards, I've had flowers, and I think patient satisfaction is very high.
We have had quite significant compliments, which has been really, really pleasing for everyone. We know that this, we all know that this service isn't going to remedy all problems, and issues that are present. But I think this, we're engaged, and we feel that this is the way forward for the future of primary care.
Using the UPCC during the past 6 to 9 months has benefited our practice greatly. It's enabled us to create extra capacity where demand has been extremely high following the COVID-19 pandemic. It's enabled our GPs to focus their time on patients with chronic health conditions, multiple complaints, by enabling us to have acute patients seen when demand is extremely high.
So it's helped with the demand to general practice, and it's very well used and utilised. So we look at the utilisation, the demand and the performance, and the uptake to the hub is highly successful.
I just wanted to say first, recruitment and promoting careers in urgent primary care is a passion of mine. I chair the Workforce and Education Group nationally for urgent primary care. And I really think this opportunity that we've had now with 24/7 has given GPs an opportunity themselves to have more of a portfolio career.
As shown, we've got lots of really experienced staff now, and we're continuously upskilling. And I think on the whole, it's had a massive benefit on the service from that point of view.
Because we're not doing home visits and we're not doing admin as much as I would be doing in a GP practice, I can maybe give patients that little bit more time to deal with them, to see them face to face on the same day, and do referrals if needed, and hopefully help the GP practice out, even if I'm referring back to them, asking them to do certain bloods or referrals. Hopefully by doing that full assessment to begin with, that's taking some of the burden off them as well. So I found it's a helpful service.
Day in, day out, face-to-face appointments are very much valued by patients, and having the ability to have an additional place where we can send patients who are appropriate to be seen is hugely valuable from a practice perspective, and is valued by patients. And often one of the things that patients are really glad obviously ability to be seen, and so people can go to the hub and be offered an appointment there, and that generally goes down very well.
One of the things that I've noticed working in the urgent care centre is certainly the positivity around it from the clinicians and the practices that are involved, but I'm also fully aware that there are practices that are in the community within the Rhondda that absolutely do not buy into it and do not want to be a part of it. And I think that's something that's going to be, we need to be very mindful of within the urgent care centre, because it is an unproven entity at the moment. We can certainly say that it works very well. But what I've seen is that the practices that are involved, and they get the benefit they get from it in terms of how their patients have good access to quick on the day appointment, I think it's a benefit for the patient and the practice, because I'm hoping that it also then relieves the workload on those practices as well.
If needed, I think developing the service so there's more clinical capacity would be a huge benefit for the practices locally.
A positive thing of being this Pathfinder being Welsh Government funded has been the networking that has taken place. We have a programme managers meeting that allows us to share that learning across all of the health boards and the different models that are taking place. And we've taken that forward within the health board as well. So in BCUHB that we have differing models at this moment in time, but we've created a forum that will help us to ensure there is a common stream throughout our models, even if they are slightly different. But it will also help us move towards a streamlined offer across North Wales.
We had weekly meetings and discussions about how the centre would work. We were lucky, and we modelled a lot of what we did on the Cardiff and Vale Urgent Care Centre, so we did have a bit of a head start, because I was aware of that centre, and I collaborated with James Martin, who set up that centre in Cardiff and Vale.
So Nick, we're staying on here now, correct?
Welcome back, everybody. I hope you've all had a break and enjoyed your breakout sessions. The next part of the agenda is for us to have a live Q&A session with guests from both the breakout sessions and other colleagues, and we'll come back to that at 12:20. Before we do that, we've got a further 2 videos to show you, which basically pick up the real local champions challenges and the workforce.
I think there are a number of challenges. I think when you're setting up an urgent care centre, what I had in my mind was that it's got to work for 3 main cohorts. And those are, it's got to work for the practices that are part of the urgent care centre. It's got to work for the clinicians who work in the urgent care centre. And obviously, and probably most importantly, it's got to work for the patients who'll be using this urgent care centre. So got to keep those things in mind. Now, the priorities for those 3 groups might not be the same. In fact, they're highly likely to be different. So it's juggling what works for everyone and trying to overcome the potential barriers.
When we started, it happened very quickly in a way. So we had to hit the ground running. So there was that logistical element of it to start with, of getting the service up and running. So that was tricky, and that was certainly a barrier because time was not on our side, and we had to get it ready within a short space of time.
From a recruitment to permanent posts here, that's also been a challenge. We are struggling to fill posts.
Some of the perceptions were challenging. Through communication and good links, we've been able to break down some of those barriers and to be able to build quite close relationships with our teams within across the health board, within the minor injuries units, within ED. And also to be able to link in with in-hours. For us, it was also key to make sure that we linked in with the local medical council, LMC, within our clinical reference group also, to ensure that we were able to work through those perceptions and to be able to work through any challenges together.
Just to say, it's been a challenging time because obviously recruiting nurses for the urgent care centres, we needed to take on the right people with the right skill sets. Training has been an issue.
Biggest initial challenge was around IT infrastructure.
Biggest barrier initially in the first few weeks was how we use the IT system and how we communicate between each other. And it's still a work in progress, but I think we found a happy medium. So the practicalities of having lots of different practices link in with the urgent care centre is that we have to navigate between lots of different sets of electronic health records for which is doable, and I think we do it pretty well. But it's knowing how to do that. So there was some logistical, technical barriers there.
Final one would be about electronic prescribing, because I think that would be a huge benefit. And Wales is about 3 to 5 years behind England, where they currently already have that in place.
One of the challenges we faced initially was around information governance and getting the right governance structures in place to allow us to connect all the different GP systems together. But we went through the process of that, and we were able to achieve that. But that certainly is something that needs to be looked at whenever you're looking at one of these projects. So yeah, information governance was definitely a challenge at the start.
How I see the urgent care centre is obviously primary care led, but also trying to encompass the wider primary care team and utilising their skills and their abilities really as much as possible.
We've gone through several different stages. At the start of the project, when it was a little bit smaller, we mainly staffed the hub with existing practice staff, and that worked fine when it was a small project, but we realised that effectively all you're doing is rearranging the same deck chairs, and it doesn't actually provide additional capacity to take a GP or another member of staff from a practice and put them in an unscheduled care hub. That's just, you know, cutting up the same cake in a slightly different way. So we realised we needed to get some additional capacity, and we strongly felt that a multidisciplinary model was best.
It was about developing a system that was available 24/7.
It's a very diverse clinical team. So we have doctors, advanced nurse practitioners, paramedics will be joining us shortly, but we also have pharmacists, and all of these are working at an advanced level.
One of our practice nurses who was doing her advanced nurse practitioner training over the last 3 years, she qualified in June. And I was her mentor for those 3 years. And then she started sitting in with me in the urgent care clinic, and now she's actually working as part of the urgent care clinic, which is working really well, with the support from myself and from the GPs that work there.
They've had lots of GP mentorship, which has been quite extraordinary, really, along the journey.
We are also hoping to expand that multidisciplinary approach to having the respiratory nurses involved with us, the community respiratory nurses. So I think that they'll be an invaluable resource for us over the winter months.
We've got physiotherapists who help to provide a degree of musculoskeletal appointments on the day, and we also have mental health appointments which are provided by a third sector organisation, Mind, who have been involved with the cluster for quite a long period of time, but we've got some additional capacity with them to do rapid turnarounds of patients who have acute mental health problems, and they can be seen within a 24-hour time period. So that gives us some support for patients with mental health problems as well.
For workforce, we were conscious that being able to appoint staff permanently was key, especially clinical staff. We'd acknowledge that sessional staff and bank staff are important for the model, but also to be able to have that sustainability. Our health board were quite supportive in ensuring we were able to appoint to key clinical posts on a permanent basis, acknowledging that the Pathfinder was only funded on a temporary basis, but knowing that we would need GPs, nurses, other clinicians on a permanent basis within the health board. And for us, it was key to be able to encourage that within the model.
In that process as well, we've had to integrate our out-of-hours nurses with the urgent care nurses. That's been quite a journey really for them, because it's been different. The in-hours nurses have had probably opportunities that some of the out-of-hours nurses didn't get. As I said, the luxury of GP mentorship constantly has been a real bonus for them all. But I think we're building bridges, we're team building, we're integrating overlapping shifts so that they get to work together, encouraging some of the in-hours nurses to try out-of-hours shifts as well.
So I've worked alongside a physio, which has been really nice. So I can bang heads with her on musculoskeletal issues or ask for her opinion, and it's really nice to be able to see a patient that needs physio and be able to book them in with them within a week. I find that a really good service.
The way that we've worked collaboratively between practices, I think that in itself is just one big multidisciplinary team, isn't it, really? You know, when you have lots of different practices who all have their own identity coming together and creating something new, that's really exciting. And the fact that the practices in this area have been able to do that is a tremendous credit to them.
Welcome back, everybody. I hope you enjoyed those videos. We've got one final video at the end of this session, which picks up how we move urgent primary care centres into phase 2. I'm delighted now to chair the question and answer session. As I said earlier on in the morning, we had a number of questions come in from colleagues who've been on the event today, and I'm joined by an expert panel who have all been part of the breakout groups over the last couple of hours. So without further ado, I'm going to take the first question that we had in earlier on. This question is going to be answered by Richard Bowen, the National Director for 111. And the question is, Richard, will NHS 111 have the ability to book appointments directly for the urgent primary care centres, as this may be important as hopefully demand for the centres increases over the winter period?
Thanks, Nick. And the simple answer is yes, absolutely. Why not? Historically, the 111 Clinical Support Hub obviously have had the ability to book patients directly into out-of-hours bases on the assumption, obviously, that appointments are available. I could see absolutely no reason why we wouldn't want to do something similar for urgent primary care centres. Again, interoperability, we'd want to put that in place anyway. We'll have far more opportunities on this, obviously, when we have the new IT system in place Q2 next year.
Okay, thanks, Richard. Okay, then the next question is around the GP workforce, and I'm going to come to Alice Groves, who's GP out of hours clinical director for Aneurin Bevan, and James Martin, who's the cluster lead for the Western Vale cluster. And the question is, the GP workforce is limited. Do the urgent primary care centres pull on a currently limited workforce and hence increase sustainability issues? So Alice, could you take that first, please?
Yeah, thanks, Nick. Appreciate that, there are sustainability issues across the patch, really, but no, what we did was that we offered our GPs that we had currently salaried jobs and offered them more of a portfolio type of career. And I think that's the way it should go, where, do a bit of in-hours, some urgent care out of hours, and also the option to do some leadership and non-clinical sessions. And I think that's what's appealing. So I think that's what is quite good to sort of, help really across the patch. So the other thing that we would be doing as well is to increase the MDT, as we do know, that there is a lack of GPs. We haven't got enough to sort of go around. So really to expand our MDT in the form of urgent care practitioners would be our next step.
Thank you, Alice. James.
Lovely, yeah, thanks Nick and Alice. First thing I would say is I've got some sympathy for that view. I think it is a valid concern, and when we look to set up our model, we realised there was no point taking a GP from a practice, putting them in an urgent care hub and getting them to see the patients they would otherwise have been seeing in a practice. That approach just doesn't make sense. So it does require additional capacity. So the way we've tried to mitigate that is very much as Alice was saying, by adopting a multidisciplinary team and trying to then grow that multidisciplinary team. So we use advanced nurse practitioners, we use independent prescribing pharmacists, and we're looking to bring some paramedics on stream as well. And we're really hoping to try and grow that team as well. So not just sort of poach them from other areas, but develop them with the team. We've always got a GP there for clinical supervision, so we view it as actually quite a good kind of hotbed to grow this multidisciplinary team. And that's the way we're trying to get around the issue of workforce, because it certainly is a challenge, and it's probably the biggest challenge that we face.
Thanks, James. So on the subject then of the MDT, I'm going to come to Kerry Phipps for this question, which is, people may still think, Kerry, of GPs when they go to the urgent primary care centres. What are the other roles in urgent primary care that have made it a truly integrated workforce approach?
Thanks, Nick. And just building on the answer from Alice and James as well, it's a really helpful question to highlight that it's vital that we provide a multi-professional approach with the right skill set to meet presenting needs in the developing urgent primary care model. And therefore the workforce to support this encompasses advanced nurse practitioners, as James said, as well as advanced paramedic practitioners, but also MSK practitioners. Now in the urgent primary care model, this is predominantly physiotherapists, but looking to our podiatry colleagues as well. And then in terms of mental health practitioners, how we seek support there. So in terms of mental health practitioners, which are predominantly occupational therapists, social workers and nurses, the developing models are looking at a whole system approach with wider occupational therapy services and third sector and wider partners as well, hence my use of multi-professional as opposed to multidisciplinary. Thank you.
Thanks, Kerry. So on the staffing, we've had a question come in that specifically sort of references the Rhonda model, and as we've got Bikram on, I thought we'd come to you, Bikram, to answer this question, which is what staffing numbers are you finding necessary to man urgent primary care centres, say for 1,000 patients? because listening to the Rhonda model example that was given earlier on, it sounds like you have one GP per day based on the current figures. So Bikram, can you give us a bit of an indication of where you are with staffing and staffing numbers and how you work your centres? Thanks.
Yeah, no, thank you, Nick. I think it really is a good question and a difficult one to answer. With unscheduled care, you just don't know what the demand is going to be on any one day. And this is why a model that encompasses many practices, like the Rhonda model and the Cardiff Vale model, is probably the best way to go, because in any one day, one practice could have very high demand and another practice very low demand. So by working with as many patients as possible, you try and iron out some of those variabilities. What we look at is utilization rates, and currently we have one GP and we've got funding to grow the model, and the reasons already mentioned by James and everyone else in terms of resources. We didn't want to pull on a very limited number of GPs. We wanted to train and utilize the skills that were already available from IP pharmacists who weren't being utilized as they could have been, and AMPs as well who were being trained, and APs, and probably not being utilized to their full potential. So we wanted to draw on that, plus recruit and train more of these skilled practitioners. So we wanted to try and have it as a GP supervised service as opposed to a GP led service for those reasons. And actually a lot of the conditions we're dealing with can be adequately dealt with in a very safe manner by IP pharmacists and AMPs who are adequately trained. So in terms of numbers, as we've grown, we looked at our utilization rate, and we have over 90% utilization. Many days, on the busy days, certainly our centres are full by around just after midday. So if anything, we could have more capacity on those days. But again, you do find the Mondays and the Fridays are the busiest days and you need more capacity, and the other days are slightly less busy. So we're looking at how we can flex our model going forward. So we could have more resource on a Monday and a Friday, and perhaps reduce the amount that we have on other days where sometimes we don't have filled appointments. So I haven't fully answered your question because I can't give you specifics on per 1,000 patients.
That's great. Thank you, Bikram. I'm going to come now to our academic colleague, Carolyn Wallace, who's joined us on the panel. So it was mentioned earlier, Carolyn, in the introduction by the Minister, and also during a number of the sessions, that the work that we've done on urgent primary care is seen as cutting edge. Can you give us a bit more detail about that and what you found in your initial research, really, that you helped us in the development of the programme?
Yes, of course, Nick. I'm referring back to the literature review, and which is available for people to read. We did a full search of the international literature and conduct to look at the evidence, and we found initially 60,000 papers, which we narrowed down to 170 papers, which told us a little bit about what was happening internationally. 16 gave us some information on definitions, 24 on information on urgent care, but there was very little information available within them, and the quality wasn't very good either. What became apparent when we were reading the literature, when we were analysing what we were seeing, was that there was no clearly articulated definition of what urgent primary care involves, and no consensus of what constituted urgent primary care centres. And we looked at, as I mentioned, international literature from England, Wales, Scotland, Germany, Denmark, Norway, Netherlands, USA, Canada, Israel. And even within the countries, there were variations in configurations and funding and workforce. There was no evidence to quantify exact period of time to which they referred, and no distinction made between urgent primary care and other forms of urgent care. So when we consider that backdrop, the actual development of an agreed definition as you described, Nick, earlier on, which is illustrated within the literature review, when you consider that, that's evidence enough to say that this is cutting edge, and the development of the services based on that agreed definition going forward tells us that the work going forward is based on agreed definitions, and we're easily able to articulate that. So in that sense, it is cutting edge.
Thanks, Carolyn. Okay, so the next question we've got is really about the communications issues and messaging to the public. And I'm going to come to Andrew Goodall, Director General, to answer this question, if I may, which is what is being done by government to get the message out that the GP is not always the best place to present. Practices are directing patients to the correct services, but patients want to be seen by GPs.
Yeah, thank you, Nick, and also thank you for sticking me into the panel. Yeah, very happy to answer this question. I mean, first of all, really important that within the system, of course, we have the ability to support the navigation of the patient, to signpost them, our Director of Services, the routes in that we have. And obviously that's when people are having a contact with us, and, you know, always want to recognise that, you know, anybody coming in and accessing care and treatment is having an individual experience despite the high volumes of care that we provide. But it is also really important that we're able to ensure that there is an understanding about the offer and the appropriateness of the services that we have across our system. And I think we can do that in a number of ways. I've been speaking today just about the challenging position the overall system has, and what I've been trying to emphasise in some of the interviews that I've done through this week is actually to talk about the fact that there will be different settings for different needs, and just to ensure that people understand that it's not always the choice that they think they need to make, and they need to have that advice and support available. But actually we do need to work on a national campaign approach. We have Help Us to Help You as our campaign in Wales. You'll remember, you know, a few years ago I was using Choose Well as the indication, and actually Help Us to Help You has landed pretty well. And what we've learned, if I could put it this way, as Welsh Government, not least because of the coronavirus experience, is a different way in which we can talk and explain things to the public. So we are really pushing on that campaign. We've invested funding in it. We need to demonstrate all of the different choices that people can make, particularly when they're accessing primary care, and that not all roads will lead to GPs because it will lead to other practitioners, and not all roads necessarily need to lead to the GP practice, of course. So I will continue to have a focus on that national campaign approach, and would really appreciate you also using that in your local communications as well. Thank you.
Thanks, Andrew. Okay, so I've then got a couple of questions which I'm going to try and answer myself. The first is around funding for buildings for out-of-hours primary care services. There's a number of points being made about sort of capital monies, and obviously recurrent revenue monies were made available to develop the service, but not any capital monies. And I think really what we would encourage you to do from a health board perspective is include your developments for urgent primary care as part of your integrated medium-term plan, which we're obviously now in the planning process for the next 3 years. So I think it's inherent on all of the health boards to look at both the capital available and the discretionary capital to try and utilise that in the best way for service developments as we move forward. And that really does link to a question that's come in that says, when do we think we will have urgent primary care centres covering the whole of Wales? And in the breakout group that I chaired a little bit earlier, we talked about the expansion of the model as we move forward, and the fact that actually a centre doesn't have to be a physical being. It can be a virtual centre, specifically in rural areas, which can be more challenging to have a build or a particular location. And I think using some of the work that has been done in Cwm Taf around the Rhondda model really lends itself to having a virtual type appointment as well as a centre to support. So I would hope as we move over the next couple of years that we'll be able to expand the service further, linking much more to, I think, to 111 and the sort of GP out of hours service that we've got across Wales, to build a coherent and consistent service available to all of the population. Which then neatly brings me to the last question, which I'm going to go round the panel in Fiona Bruce style at the end of question time approach, which is, what do we think have been the significant benefits of urgent primary care centres? And if I go round the screen in front of me, I think we've probably got about 30 seconds each to answer this question. So I'll start with Simon from Betsy, please, Simon. You're on mute, Simon.
So we set our urgent primary care centre in November last year. What we wanted to achieve was increase capacity at a time when, in general practice, we were under the cosh in terms of demand, access to premises because of COVID regulations, and of course, a recovering country, and we achieved that. So I think what we were most conscious of in terms of the benefits was that additional capacity. Several thousand contacts over the period. We got up to about 1,200 a month in the early months. So for us, it was that additional capacity at a time when we were recovering.
Thanks, Simon. Rebecca from ABUHB.
Thanks, Nick. I think for us, the significant benefit has been the integrated working across all health boards and actually developing a model for Wales. I think today we've heard about 2 distinct models for cluster and health board, but it's how they've integrated and for us to learn from each other as to which pathways that we have in place for our patients and how they link into urgent primary care as a whole. And as you say, not just centres that are physical, but virtually also. So it's about linking all of those items together, learning from each other to be able to develop a model that's across Wales and also identifies those individual needs in order for us to have our local differentiation within the health boards, but linking still into that wider model.
Thanks, Rebecca. I'm going to come to James next in the Western Vale and the Cardiff and Vale clusters.
So I think probably locally the biggest benefit from this was having a flexible additional capacity that really enabled us to respond to the challenges of COVID, to support practices, support out of hours, and being able to adapt to that, go through different phases where we became a COVID hub and then we reverted back to our original vision. That's been the biggest benefit that we've experienced.
Thanks, James. Bikram, you're on mute as well, Bikram.
Sorry, yeah, all of those things really as well for the Rhondda model. I think one of the biggest benefits for us is actually working collaboratively with other practices to develop a model for primary care and for urgent primary care that's fit for the future, trying to incorporate all the new skills and the new practitioners that are going to be coming into primary care and already started to come into primary care and really develop something that's going to be fit for the future and provide better access for patients.
Thank you. I think I'll then come to Alice Groves.
Yeah, thanks, Nick. I think, benefits to the patients, those that have that same day urgent care need, where we've already got high demand across primary and secondary care. I really think these urgent care centres can relieve the pressure on both of those. And, those patients who really need to see somebody or speak to somebody that same day with their urgent care needs, this is something that we can and will provide for them.
Okay, thanks, Alice. So just taking a couple more comments, I think. Richard, from a NHS 111 perspective, you've obviously, alongside myself, been leading this work. So what do you see as the key benefits in terms of the service delivery?
It's all been said, hasn't it, Nick? But for us going forward, consistency of approach, increased capacity, that interaction, I think, between senior clinicians to manage some of these patients in a different way. And dare I say it, that ability for face-to-face as well, because, we shouldn't forget that actually a number of patients do need that face-to-face appointment. So for us, some significant step forwards.
Okay. And then finally, Kerry.
Thanks, Nick. I think it's just to build on what everyone said. It's that really supporting people with the right skill set to meet their needs in a timely manner, and the opportunity that this has brought in terms of that multi-professional approach to optimise that utilisation and as a lever to that transformation we need going forward.
Thanks. Well, thanks, panel, for answering all of the questions that we've had in this morning. We're going to move shortly to the final video, and then I'm going to ask Andrew Goodall to close the event in a few minutes' time. Before we get to the video, I just wanted to add my thanks, because the majority of the people on the panel have been really integral in delivering this service over the last 12 months. And whilst I sit as the chair of the 24/7 primary care group, without the sort of 7 or 8 people who are sat around the Celebrity Squares screen now, we wouldn't have got this project off the ground or delivered. So on a personal level, I think you've done a fantastic job, and I've really enjoyed working with you over the last 12 months to deliver this. So if we are ready now, I think we'll move now to the last video of the day. Thank you.
the learning point, I think, is what we're taking from out of hours as well, which is that we need to look at more of an MDT, and we need to look at salaried posts as well to give us a bit more sustainability, as well as looking at the opportunities of co-location in terms of cross-cover with other services.
So from an opportunity point of view, there is opportunity for us to expand and take on more primary care activity, or even semi-specialist activity, such as, looking at things like D-dimers and CRP checks, which may mitigate sending somebody into hospital.
In the future, we are again looking to try and expand the capacity of the hub. So we are looking to bring on board paramedics, so paramedics who have an advanced scope of practice, some of whom are independent prescribers, and they'll be there to provide additional workforce. And we feel that having that MDT model always with GP supervision from a governance perspective gives us the capacity to run the hub effectively and safely as well.
There's more that we need to do to increase the numbers coming through this system. But as we said previously, we're facing challenges that to do that with demand in the system. Plans is really to build on these urgent care centres, to build the multidisciplinary team, and perhaps do more things to take pressure off secondary care. So looking at, can we do near point testing, X-rays, so that we can see those low level sort of patients that just need that bit of investigation rather than going into hospital for a few days for that.
We have to look at sustainability, and there's two ways that we've looked at that. There's just the fact that we've now got an extended period, so we can offer contracted posts. So we are looking at GPs and further MDT in terms of things like paramedics and pharmacists to offer that face-to-face element side of things. But we're also looking at ways in which we can utilise the other primary care services we've got, whether that's 111 contact first, the acute GP unit, GP out of hours, in an integrated way, both in terms of sustainability, but in terms of having it work as one system more than anything else.
I think we would like to integrate with minor injuries unit. I think it's underutilised at YCR. They've got lots more room. It allows us to expand as an urgent care centre to offer a lot more sort of acute service, as well as incorporate some of the other services that we're bringing in via cluster funding, such as the mind active monitoring, mental health practitioners, physiotherapists. So we can really have an all singing, all dancing sort of centre which can deal with primary care, acute primary care, as well as some chronic primary care issues as well.
What we're currently looking to do is possibly put some support into Ystrad, YWF, to integrate with MIU there, possibly a nurse-led clinic that will help to manage some of the patients that come in with minor illness, really. We're hoping that will take some of the pressure off the front door at Ystrad there.
Open up a third centre within Wrexham and Flintshire, and to help us make the most of that third unit, we're actually currently asking practices where they would like to see the unit opened up.
We've got a long-term vision of what we'd like to achieve with the hub. We're currently operating out of a GP branch surgery, which is fine in its current state, but we would like ideally to move to Barry Hospital, which is a community hospital, which is not currently being fully utilised, we don't feel, and we'd really like to keep that facility for the local community.
I suppose as with a lot of these acute services, I think increasing the scope of patients that are seen to incorporate other kind of subspecialities or patients with other conditions.
Moving forward, we would welcome various contributions of our GP colleagues, both in terms of feedback to the current work and future development. We would also be encouraging active engagement in terms of working for UPCC and referring when appropriate.
It's by no means finished. We've got lots that we want to do to be able to develop this further, to be able to see more patients come through our doors, to be able to develop our staff as well as our patients, and the integration across the wider health board and the health system, just to ensure that we are as productive as we can be, to ensure that we have all the pathways in place that we need to be able to move forward for our patients.
Okay, thank you. And I hope you enjoyed the last of our videos today. In closing today's event, I'm now have pleasure in handing over to Dr. Andrew Goodall, who is the Director General and Chief Executive of NHS Wales, to close the event. Thank you, Andrew.
Diolch yn fawr, Nick, ac prynhawn da pawb. So thank you very much, Nick, and good afternoon, everybody. As I go into my last week as NHS Wales Chief Executive, I'm really pleased to be able to provide some personal closing comments to this event. And just to say, Nick, that I've really enjoyed listening in over the last 3 hours in this virtual event. It's unfortunate that we're not able to gather in the way we have done around primary care in the past, but I just wanted to say to everybody, thank you for setting aside the time on a really important event. This has been the first of a series of learning events under the umbrella of the 6 goals for urgent emergency care, which we launched back in the summer. And I think that it's significant and a deliberate choice that this has been hosted by the Strategic Programme for Primary Care and been given over to considering the contribution of urgent primary care within the whole pathway, and not least on a day, as the Minister announced earlier, that we launch our winter plan. I think that it signals the coming together of discrete national programmes in a really collaborative way that represents the patient pathway. And for me, it emphasises the importance of tracking our pressures and problems through our patients' eyes and across our settings. The majority of daily contacts with the NHS, as you all know, in terms of your own day-to-day roles, are actually undertaken in primary care, and it's therefore a fundamental part of the whole system. And without its contribution today, and actually over the course of the NHS offer wouldn't be effective, patient-centred or local. So I think that ensuring that the primary care offer is right and it's well connected to the other parts of the system is essential if we're to provide the right service to the patient as close to home as possible. And this applies to planned and urgent primary care, and these new ways of working are really key to ensure that the NHS keeps improving its urgent care offer and is aligned to the modern day world. Teleconsultations are a key component of this and are popular, we know, with a huge proportion of our population. And going forward, we need to consider the role of telephone, digital and face-to-face in the services we provide, and navigate patients to the most appropriate setting for their care and the most appropriate professional. Today's session has explored the art of the possible in urgent primary care, and at a time as we have reflected that our system is at its most challenged. And despite all of the extraordinary efforts of all of our staff over the last 20 months, and I thank everybody for their contributions, for me right now, this is the most challenging period. And it's a combination of demand, coronavirus, patient experience, and a desire to restore normal activities that we have stepped away from over the course of the last 20 months. We've heard today how staff have worked together collaboratively, and I would really like to thank all of those involved in driving this forward. This work has been done at the most challenging of times, as I've said, and the commitment to deliver is evident in the progress made. We've heard how practices, clusters and health boards have come together to deliver this. And what has really impressed me most is that we have heard from the local sites and have that local experience to listen to and hopefully allow ourselves to make changes across Wales. And this has demonstrated how our people and our staff on the front line have informed, led and delivered innovative new services. And I have to say, at a pace and urgency that has really impressed us and teaches us about how we can make change happen in the future. And I think it's a great example of empowering our workforce to design and deliver together. However, the challenging times are not over, and as you know from your own experiences, we continue to face increasing pressures as we go into what looks to be one of our most difficult winters. And it's in recognition of these pressures that the Minister wanted to launch the Health and Social Care Winter Plan here this morning. You collectively, and you know this, have a big part to play in seeing us through the next few months by continuing to change the way that we deliver key services in line with a healthier Wales. And Healthier Wales remains our blueprint for a better future. The urgent primary care contribution has never been more important for our patients, and this winter will be no exception. And I've already mentioned that by getting this right, we ensure that patients are seen in the right place as close to home as possible. But also, it provides benefits beyond the urgent care need. It enables general practice to focus on the management of patients with chronic conditions and to address the long-term condition clinical backlog for emergency departments to concentrate on those with priority and emergency needs. Primary care plays a vital role in the management of respiratory conditions, which are a major concern during winter, and of course are therefore a key priority in our winter plan. So to function best, we need to get the interfaces between services right, and this has been explored today and is highlighted in the winter plan. And these discussions need to continue to reinforce the links with 111, social care, emergency departments, same-day emergency care, and other services, again, as you have been hearing through the course of the morning. Whilst these urgent primary care developments have been designed, led and delivered by the front line, they are absolutely grounded with our strategic aim in Wales. So this is not an initiative. We've been building and refining this over the last 3 years. And I hope that this is reinforced by the 2 years funding going forward from April to support the role of the work that we've seen today. And we want to see a clear urgent primary care offer across Wales. And there is still some way to go to achieve this. I would like us to keep challenging the model so that we are constantly innovating and improving the care we provide, and also to enable an environment that's appropriate for our own staff to provide the care that they wish. And in particular, I want to see this as part of the whole pathway offer and not separate. So if you're stimulated by what you've heard today and think there is something that you can do in your local area, then please contact the team who will be able to offer support, help by sharing further information, as well as potentially providing funding for the right proposals. I want to acknowledge the fantastic work that you have done to date. The model is here to stay, and I thank all those involved in their work to date and would encourage us to continue to work collaboratively to ensure that we're delivering optimum urgent primary care services to keep Wales at the forefront of healthcare and ensure the best possible service for our population, the winter and beyond. And we need to convert this learning event with the others that will take place that bring together impact and innovation against all of the 6 goals. And fundamentally, this is about patient safety, patient care, and experience. And we really need to maximise the impact of our system actions, and of course with urgency. So just to finish, Nick, thank you for everything that you have all done for the population for Wales and continue to do, and of course in these extraordinary times. Diolch yn fawr iawn.